So let me just share. And you just confirm that they can hear you. Okay, so that screen not going away. That screen go away. All right, sorry about that. We wanted to make sure that everybody could hear us. We're hosting the meeting here in Bridgewater and also Zooming in Babson and Northampton, so we just want to make sure everybody could hear. But again, thank you so much for being here this morning with us. Our program this morning focuses on the regional support team and care management and also family and child care support services. That was a recommendation that we received from MHCCs and wanted to have more information on how to provide that. That will be a breakout session after we present the regional support team information. And then another recommendation from everybody was to have the team review the PPOC 2019 goals and then allow collaboration and networking with each other to see what have practices identified for a PDSA goal and what were some of those steps that you took so that we can learn from each other. Wanted to disclose that we have no financial relationships or anything else to disclose with this presentation. Just trying to get that top bar to go away. Anna, do you know how to make the bar go away? I just want to get it. There it goes. Okay. Okay, and then just a couple announcements that in Babson, there are microphones throughout the room. So if you can just keep side conversations to a minimum there so that they don't come through on the recording. And then also at the end of the meeting, if you could just return your name tags. So the objectives for this meeting is through the participation, the end of the MHCC longitudinal meeting, you'll be able to discuss different types of family and child care issues that affect your patients within pediatric primary care. And then you'll also be able to discuss processes to address those barriers. And you'll be able to list 2 or more community-based services that can provide services and supports for families under child care services. There are 2 nursing CEUs accredited for this MHCC longitudinal meeting. In order to obtain those CEUs, you'll need to be able to sign in and then also complete the post-survey session. And those certificates will be emailed. And this is an overview of the PPOC MHCC program support. Tammy Kolpolsky is our leader. She is the Director of Quality. My name, again, is Cheryl Smith. I'm the Manager of Patient Safety and Medical Home Care Coordination. We have Anna Porter and Nicole Pelletier, Carlos, and then also your practice consultants that are assigned to your practices. And the practice consultants by region are Topay and Virginia in the north, Megan and Anna in the south, Brad, Carlos, and Jane in Metro West, and Scarlett Grassetti is new in Western Mass. She has taken over all the Western Mass practices as a practice consultant. And then our guests that will be providing an overview of family and child care support services within our communities are Child Care Circuit and Family Ties of Massachusetts. And then we have some new medical home care coordinators to welcome with us today. Julia from Arlington Pediatric Associates, Allie from Newton Wellesley Children's Doctor, Marcia from Child Health Center, Courtney from Village Pediatrics, Erica from Chestnut Hill Pediatrics, and Ashley from Bridgewater. Welcome, and we're so happy to have you. If you need any assistance while you're going through your onboarding and training, please don't hesitate to reach out to one of the members of the medical home team, your practice consultant, and also Ileana has a wealth of knowledge that she provides a lot of guidance for new MHCCs as well as experience. These are our advisory board members for the medical home, and again, they are very valuable for all MHCCs, but especially if you're new to the role, please don't hesitate to reach out to one of them. They are very happy to mentor anybody in their role. And then, so our first component of our program is an overview of the regional support team and care management. And I'm going to stop sharing and switch over to Nicole. She's going to give a demonstration of Open Peds.
Thanks, Cheryl. Can you hear us okay? Cheryl, can you hear me okay?
Anna, do you know how to get this to minimize once I stop sharing? So they can see the slide. I don't want to end the meeting by accident.
Cheryl, can you hear us? Sorry about that. Just one moment. I just want to make sure that they can hear us okay. Cheryl or Dan, can you hear us?
Yeah.
No? They could before.
Yeah.
Yeah.
We hear you just fine.
Okay, thanks, Dan.
Mhm.
Maybe they're just, let's give them 1 minute to make sure that they're all set. Do you just check with Anna? Okay, we will just get started. So we wanted to start today by announcing a couple of changes to the online platforms that we use to communicate with all of you and help support your work. So I'm sure many of you, hopefully all of you, are familiar with Blackboard, which is the current online platform that we use, that we put our online resource guide. We have all of the versions of the health needs assessment. We have our curriculum modules. Everything's on Blackboard right now. As of June 21st, we are going to be transitioning from Blackboard to a new platform called Open Pediatrics. So Blackboard will be going away as of June 21st. So we wanted to show you a little bit about Open Pediatrics today, and some of the new features that we hope will be very helpful and a bit more user-friendly than Blackboard was. So in your packets that you all have are instructions for signing up for Open Pediatrics. So in order to be enrolled in our medical home care coordinator group, you need to first have an Open Pediatrics account. Unfortunately, we cannot create the account for you. You have to initiate the account. So please go through, follow those instructions and create your account by June 7th, and then we will enroll everybody in the group. One of the great things about Open Pediatrics is that anybody can have an account. So as some of you probably remember, with Blackboard, we had to limit it to one account per practice. But with Open Pediatrics, anyone in your practice can have an account. Some of you may be familiar with Open Pediatrics. The PPOC's recently started using it for a practice manager group as well. So I am currently signed into Open Pediatrics. I will just put a disclaimer that my access does look a little bit different than yours. I'm an administrator, but for the most part, the features are the same. So when you log in, you can go to My Groups, and then select the Medical Home Care Coordinator group. On the home page, we have some general information. If we have any announcements, such as upcoming longitudinal meetings, it'll be here. The contact information for the regional support team is also here as well. Then the next tab is the Resources tab. So this works a little differently than the resources in Blackboard. So rather than have a PPOC curated list of community resources, we are going to be using an external platform, which I'll talk about in a minute. So the resources on Open Pediatrics are a little bit different. You won't be able to find, a local food pantry or something like that, but you will be able to find on here our curriculum. So I would strongly recommend that if you have not gone through the curriculum, that once you get your Open Peds account, you do. I think we mentioned that a couple months ago, we've revamped this and we've made it a lot more relevant to the work you're all doing, and we would really recommend that you go through it if you haven't already. But Open Peds is very easy to navigate. Just click on the links and it'll bring up the syllabus or whatever the document may be, if it's an external link. In addition to the curriculum, we also have all of the versions of the health needs assessment in all of the languages. So you can either click on the link or click the little arrow and it'll show you everything in that folder. So these are all the versions of the health needs assessment. They're all Word versions, so you can add your logos. We also have all of the information from past longitudinal meetings. We're still building this out, but all of the information will be there. So you'll be able to look by date, you'll see the topic, and then you can see any slides, if there was a recording, any handouts are available right there for you. We do have in here some educational resources and training opportunities. These are more so either slides from a training or a conference maybe. For example, we have a TED Talk. We have some slides from a housing presentation. So again, you won't find community resources here, but rather educational resources. Open Pediatrics also has discussion boards. Once we all get up and running, we're going to be really looking to start using these discussion boards to allow all of you to communicate with each other, more than just in these quarterly meetings. So if you need help looking for a resource, or if you found a great resource you want to share, or just have a question about care coordination, you can post it in the discussion board. You can also see a list of members. So if you wanted to reach out to somebody in particular, you could do that as well. Once everyone's enrolled, everyone will be here. And like I said, these other buttons we won't be using. So I'll pause for a minute to see if there's any questions about Open Pediatrics. Yeah.
You said there's not resources, just educational resources? Where are the resources?
I will show you right now. Oh, I'm sorry. The question is, where are the community resources? Okay, so first, just a reminder, please create your account. There's instructions in your packet. So our new resource guide, instead of using the Blackboard resource guide, which again is PPOC maintained, we are going to be using a new third-party resource called Help Steps. And I will demo that for you right now. So Help Steps is a free resource. You don't need to register or create an account of any kind. There's also a mobile app that you can get on your phone. This is available to everyone. You can refer your patients and families to this resource as well. So some things that are really great about it is that it is maintained by a group at Boston Children's, but it's connected to Mass 211. So they have all of those resources. They collaborate with Boston Public Health Commission, United Way, a lot of other organizations, and they have resources throughout the state. So it's not just focused in Boston. As you can see, one great feature that we didn't have in Blackboard is the ability to search. So when you're looking for a resource, you can either, if you know the category that it's in, you can click one of these categories over here, or you can search by location. So if I was looking for a food bank in, say, Malden, and then, oops. There we go. So it shows you all of the resources. It shows you how far away they are. So let's say I was interested in referring my patient to the Newton Food Pantry. Go to this website, it has some information, takes me directly to the website, gives me information about their address, their services, their hours. There's also the ability to share the resource. So you can send it directly to the patient by text, email, or generate a PDF to print and hand to them. So for example, if I wanted to generate a PDF to hand to them, you could give them this. It has all of the information about the resource. Again, you can also text it or email it to them. And there are many resources. In here we have, all of the categories of our needs assessment plus more, nutrition, housing, food, education. And we are going to be working with Help Steps to make sure all of the resources that are on our current Blackboard resource guide are available on Help Steps. They have a much more comprehensive list than we did, and it's maintained updated on a yearly basis. So we hope that this tool will be easier for you all to navigate, find the resources you need, and then also have a really great way to send them to your patients without you having to make your own documents or maintain your own list of printouts. And so this is available right now. I encourage you to all look at it today. As I said, you don't need an account. It's free, and there is a mobile app available. And the address is just helpsteps.com. Let me see if there are any questions about Help Steps. Yeah.
Do you text them? Are they then gonna have my personal?
No, it sends the text from like Help Steps, not from you. Mm-hmm. Yeah, and so this is just sending the resource. There's no exchange of patient information, so you don't have to worry about anything like that. Okay, well, if you think of anything, please feel free to reach out to us. Okay, and with that, I am going to transition back to Rick.
Sorry for the technical difficulties during that transition. We thought it would go a little smoother going back and forth between the locations. But in addition to reviewing the transition from Blackboard to Help Steps and OpenPeds, we wanted to review the regional support team process as well. I know we gave a lot of information at the last longitudinal meeting, and there was a few questions. So we just wanted to review it again to be sure that everybody understood some of the changes that we made when we tried to rebrand and standardize everything. So within the regional support team, there's two levels of supports that are provided by the PPOC. Level 1 is with Ileana, who's our resource specialist, and that looks at the lower level complexities with socioeconomic and payer coordination needs, and the higher complexities with medical complexities and social economic needs, which involve telephonic and home visits with community health workers in level 2. And then the referral pathways, the way that you refer into the regional support team with PPOC. From the medical home, there's 4 types of referrals that would go into the regional support team. It would be for that level 1, which is the lower level complexity, level 2, which has in-home visits, if you want to refer to Tufts Care Management or to LTSS. All of that would come into the regional support line, and you can do that through the phone number, which is listed here, and there was also the email, which is the regional support team email at chpppoc.org. In addition to the referrals that come into the regional support team, there's also the external referrals from Tufts Management and LTSS. The reason we have that coming into the regional support team is we wanted to keep you into the center of the information for all the care that's occurring with your patients, because we had found it was a little disconnected. We were working in silos, and we want to make sure that you as the MHCC and the provider, that you have all the information that's occurring with your patients. And when you're making that referral into the regional support team, you may not know what type of referral you want. You might have identified there's a barrier or a gap. You're not sure what to do. You need some help. Just call into us and we can help determine which pathway it should take. It might be Ileana just providing some advice and guidance to you, or it might be us taking it into the regional support team, or we might say, let's refer to Tufts Care Management, or they meet criteria for LTSS. And when sending that referral in, this is just a few examples of information that you can send in with that referral. It looks like a lot of information. Really, at a minimum, when you call in to Ileana or email, all we need is your name, your role, the practice that you're calling from, the patient's name, date of birth, medical record number, and the reason for referral. Everything else, we have access to Epic, so we can look that up as well. But ideally, what we'd like to occur, once that comes in either through the phone line or email, Ileana will reach out to you, or if it was escalated up to another member of the regional support team, they would reach out, because ideally we'd like to have that verbal handoff so we can learn, what really were those gaps and barriers, what have you tried already that didn't work, or where did you keep, hitting a barrier. And then as we provide, work with the patient and family, we'll communicate the same back to you, especially on closure as they graduate from the regional support team and we're handed back to you. There'll be another handoff because again, we want you to be in the center of all that information. And so level 1 is with Ileana, and she's here in Bridgewater. She is our resource specialist, and she has a wealth of knowledge. When you call her, you know, she's aware of all the community resources, and she could, even just a quick call to you, she can provide advice and guidance. And then our level 2 is with the community health workers providing in-home visits. And congratulations to Dan Barrio. He was initially a practice consultant in Western Mass and our regional manager of Western Mass. And he was recently promoted to the program director for the regional support team. So he will provide oversight and guidance to all region members and the leaders in those regions to try to standardize everything because it was not as standardized. So that was part of our rebranding. We want to make sure what we're offering in one region, we can make available in all regions. And Jane O'Brien is in Western Mass. She's a nurse complex care manager. And Jasmine and Damaris are community health workers. Cyndi Cooks is the leader in the South, and the community health workers you may be familiar with: Celia, Anna, Grace, and Jason. And Lynne Sullivan is a new member of our team. She's the manager in the North region. Tamar is a new community health worker. She joined us a couple months ago, and Jennifer just started this week, and they are both community health workers in the North. And so to share an example of a type of case and what we can do with the regional support team where we work collaboratively with you, there was a case that was actually a phone call that came into patient safety. The practice wasn't quite sure what to do next. Weren't sure if they should file a 51A. A little bit of a background: there were 2 children, siblings, 6-year-old and a 1-year-old that had been sick for about 2 weeks. They were seen in one office visit. Mom had called to make some follow-up visits because the children were still sick, but did not show or had canceled those appointments. The provider had reached out to the mom, spoke to her on the telephone, and during that conversation, the provider was concerned for the child, that felt that they had gotten, that they had worsened, and had recommended that the mom hang up the phone, call 911, and go to the ED. And then they had lost communication. They had kept checking the Epic records to see if there was any ED documentation, had made multiple phone calls and could not get a hold of mom. And so they were very concerned for the children. So when they had called, so when we were thinking about it, we said, rather than file a 51A, because we didn't know, was there a reason she couldn't make it to the practice, reason they weren't answering the phone? So we said, why don't we refer it to the regional support team level 2? We'll send a community health worker out to the home. So when the practice called, I think it was about 11 in the morning, and our community health worker was able to go out that afternoon, I think around 3 o'clock. Mom had answered the door, and she had explained why she was there, just that the provider was concerned and just wanted to make sure the children were okay and if they needed any assistance because she hadn't been able to make it to the appointment. Mom welcomed her into the house, and she was able to see both children were okay. The 6-year-old was running around playing. The baby she saw sleeping in another room, but the door was open. She could see. Baby didn't look to be in any distress. Mom had said children were better. The 6-year-old had returned to school. So the community health worker did a health needs assessment, and during that health needs assessment, she had identified the reason the practice couldn't reach mom. She didn't have a phone at home. The only phone they had was with her boyfriend, who took it to work. So we were able through that to be able to contact Tufts, and Tufts provided a phone for mom, a cell phone. They had mailed it out to her. Mom also didn't have any transportation. That's why she couldn't get to the sick appointment when her boyfriend was working. There was no car at home. And she had also missed an appointment that was at BCH at Waltham. So the community health worker was able to, PT1 had already been approved, but she was able to call BCH and reschedule that mom, so it was convenient, and also helped set up transportation. And then mom had said how her child, the 6-year-old, had frequently been in the ED due to asthma. And so the community health worker also reached out to the practice to see if it would be okay to enroll her into our medical home asthma program. So while she was there, she did the first home asthma assessment and visit. And then also mom had said that she needed some health forms for school. So the CHW was able to communicate with the practice as well to let them know that they needed the forms to help facilitate that. Had provided the boyfriend's the cell number, because mom had said it was okay to leave a message on that if they wanted to reach her, and she would follow back up. And since that home visit, mom has the cell phone that Tufts was able to provide. There was actually 2 asthma home visits already completed, and the 3rd one is scheduled. And then there was closure and follow up with the practice as well. So it's examples like that where we kind of think out of the box and try to collaborate with you to help get you the information Other times you might send a referral into us for one reason, and when we connect with the family, there might be other things through that relationship building that we identify, and we're able to communicate back to you, again, always keeping you in the center of information. And then I just wanted to review the LTSS, the Long-Term Support Services Community Partners Participation Form. We went over this quickly at the last meeting, and there was a couple questions. So I just wanted to review it just to be sure that we were on the same page and for you an opportunity to ask any questions as well. But there were some challenges with community partners. We had said that you couldn't provide any information until you received that participation form. And we had clarified that for the last meeting, that you can verbally clarify with the community partners. If they call you for information, you can ask them if they have a signed participation form. If they say yes, they have it, it is okay to share the information. Another way to verify that there's a participation form, if the community partner sends a care plan, then that's acknowledgement as well that there's been a participation form signed, because they cannot create that care plan without consent from the family. Or if they actually send you the consent form, then you know that you have it. If none of that can be verified, then the only way that they can receive information is to refer them back to the BCH HCO LTSS team, and the email is right there. I'll stop for a minute to see if there's any questions. I know I went through quite a bit just now. Any questions on that? Hi, Maureen.
I actually have a question. Is the LTSS and children different than the regional support?
Yes. Okay, so the LTSS is a long-term support services program. So there's 9 community agencies that the BCH ACO has contracted with, and those are based off of regions. And then the regional support team are members from the PPOC. So, oh, I'm sorry. The question that Maureen had asked is if the LTSS program on community partners is the same as the regional support team.
Actually, no. I understand what LTSS is.
Okay.
But when you say reach out to regional support for LTSS, like, is this a different contact? Like, we're going to bypass regional and go to the LTSS?
No, that was if they need questions, you would refer the community partners to reach back to BCH ACO. So the question was just why the difference with this email versus where we had said to call into the regional support team. So if the community partners does not have a signed participation form and they need patient information, you would ask them to contact the BCH ACO, because Chico can help provide that patient information. But back to their RST referral process, say a patient has not been identified meeting criteria, you haven't heard that they're on the LTSS list, but you're aware of the criteria and you think that they might benefit from that program, you can call into regional support team and we can help facilitate the referral to LTSS. And we would use it through the same email, but we're trying to standardize it and not make it confusing where you have to email or contact all these different parties, where if you just come to the regional support team, we can help get it in the direction where it needs to go. Did that answer your question, Maureen? Okay. Any other questions? And then what we wanted to recommend, because we are sharing a lot of protected health information between community partners, the regional support team, Tufts, the practices, is we strongly want to encourage that you use a secure encrypted email. And if you don't have one for your practice, the PPOC does offer 3 secure emails, one for the office manager, so it would be your practice name _OM@chppOC.org. There's one for the practice for clinical, and then also the medical home care coordinator. So if you don't have that and you don't have a secure encrypted email, we can help get that set up if you send the PPOC service desk a ticket. And then also, if any information changes with your MHC or staff members, let your practice consultant know. That's how we update our database, so that when we're sending out reports or that LTSS report is being sent, we want to make sure that we're sending it to the right person so it gets there efficiently and timely for you. And then I'm going to transition again to Nicole, and I hope it goes a little bit smoother than last time. I'm going to stop sharing.
Hi guys, all right, we're just going to give a minute to make sure that Bridgewater can hear us. While we're waiting, let's pause. Are there any questions in the room here about anything we've talked about today? All right, we're just going to give them 1 minute to just reconnect. they are all set. So we wanted to provide a quick update. Some of you may have noticed, if you have tried to run any report in Epic since the upgrade last week, that if you go to edit a report, the pop-up screen that you get with the different options for adding different columns or changing the criteria looks a little different with the upgrade. And we just wanted to let you know that there is a training video available on Learning at PPOC. That outlines the changes to the reporting screen. Also, if you have any questions, feel free to contact your practice consultant or the service desk. We're happy to work with you, but just want to let everyone know that that training is available. Okay, so now we're going to transition a little bit and talk a bit more about the needs assessment and also some family and child care support services. So we wanted to give an update. So we, as you all know, rolled out the new PPOC Health Needs Assessment about a year ago, actually on May 22nd. So exactly 1 year ago. So to date, well, actually as of the end of April, we have, well, I should say you all have completed needs assessments on 25% of our PPOC population. That is 93,000 patients. So just want to give a quick round of applause to all of you for all of the hard work that you've done. So that means that 84% of you all have completed at least 5 health needs assessments. So we have some practices that are still getting started with the process. And almost half of PPOC practices have completed needs assessments on a quarter or more of their patient panel. So what we have found from the results from the needs assessments, we showed some similar numbers a couple months ago, and the top 3 categories of needs have remained the same. So those are problems with pests, mold, water leaks, smoke detectors, as well as utility services, and finally, support from other people or programs. So that is the area where patients and families have been identifying the highest need on the health needs assessment, which is why we wanted to focus our session today on providing you with some additional resources and support to help families if they identify this need. So we just wanted to give you a little bit of background data on kind of why this is important. So there's been, a few studies and censuses done. Right now, more than 60% of parents across all income brackets say it's hard to find affordable, high-quality childcare in their community. Back in 2011, families in poverty who paid for childcare spent a greater proportion of their monthly income on childcare than did families at or above the poverty line. In Massachusetts, 62% of children in low-income families live with a single parent, and 18% of children in the above low-income families live with a single parent. So those might be families that are in need of childcare services. So now we want to break into some regional presentations and tell you a bit more about some services in your communities. So the first service that we want to talk about is the Child Care Resource and Referral Agencies. These agencies support local communities by assisting families in finding childcare that meets their needs and helping eligible families obtain childcare financial assistance. There are multiple of these agencies throughout Massachusetts. As you can see on the slide here, there's also a link to mass.gov. I know that might be a bit hard to see, but you can look and see in your region who your local agency is. We are lucky today that we have one of these agencies here with us in Babson. We have Corinne from Child Care Circuit, and she's going to be talking about the services that they provide. And so while some of their services are specific to the North Metro West region, a lot of the services are also ones that are provided at other agencies throughout the state. So we are going to have her give her presentation, and after that we are going to break out into regional groups and talk about family ties. So with that,
morning. My name is Donna Chaplin. I am the Southeast, can everyone hear me? Yes. I am the Southeast Regional Coordinator for Family Ties. And basically, I'm here today to talk about our program and what we offer and ways that we serve the community. My screen's not moving. Excuse me, I have some type of my screen's not moving.
It did the same thing to me earlier.
Just push that. Yeah, let me see, it did the same thing to. Oh, no, wait a minute, you should be able to. There you go, okay. So sorry.
No, that's okay.
So who we are, Family Ties is a statewide information and referral service for parents. And what we do is that we match or find resources for parents in the areas in which we cover. I'm the Southeast Regional Coordinator, so I cover anywhere from Canton, Taunton, to all the way down to the Cape and Islands. We find services for parents who have children with special health care needs and/or learning disabilities. We are a grant project that is funded by the Federation of Children with Special Needs and the Department of Public Health. There are 6 regional coordinators. I am one of 6. There's also a parent-to-parent support staff. Her name is Gloria Klaskas. And we are all parents of children with special needs or special health care needs. So we offer a very unique type of support to parents. How I found out about the Federation of Children with Special Needs and Family Ties is I'm the mother of 2 children with learning disabilities. And I had a 5th grader that was moving on to the 6th grade who could not read, was reading at a 2nd grade level. And I called Family Ties and was referred to the Federation of Children with Special Needs and did one of their trainings to find out about IEPs and understand my daughter's educational profile. And it changed her life. Today is her last day of high school. And she will be, she's graduating with honors. And she will be starting Mass College of Art in the fall. So I'm here to give back, to pay it forward. And when we have families that call us who need help, regardless of what it is, we really work hard to find services. First and foremost, we are the central registry for early intervention. So when doctors refer families to early intervention, they usually call us first, and we find the catchment area in which they need to call. We also have other programs. The Parent Training and Information Center is something that we do as well. And we offer training for parents to come in to find out how to service and meet their children's needs. Another big part of our program is, on the right slide. Okay, so here's what we do. We're the regional coordinators. I went over that already, got ahead of myself. I do apologize. One big part of our program is parent to parent. And what happens is a parent will call and say, I have a child with a special healthcare need or a rare genetic condition, and she's looking for some type of support. Regardless of what it is, our parent-to-parent coordinator, she scours the country. She's part of a national database, and she'll find another parent to match that family with so they can lend support to each other. Usually they're a year or 2 older, or sometimes they can be up to 5 years older, just to say, I went through this, I went through that, this is what happened at this time. So it offers a very unique type of support to parents. We do have our Share Your Voice Family Advisor Program. And this is the parents' opportunity and also providers to get in touch with DPHs to let them know what you guys are seeing on the ground. If you want to be part of focus groups, we do surveys, advisory boards. And sometimes parents let us know that things aren't working, things that are working that they need to see more of, whether it be play groups, more specialized instructions in camps and things of that nature. So this is very important. And they call 800 line to request enrollment, and you can also download the information from our website. One of the big initiatives of the Department of Public Health is the medical home. And We honor our patients, our clients' experience and their culture. We offer most of everything in your packet comes in multiple languages. And for the languages that you don't see, we actually have a toll-free, we have a language line that families can call in and speak to someone of that language: Arabic, Mandarin, Creole, Haitian Creole, French, Spanish, Portuguese. So when a parent calls and English is not their first language, they're very comfortable in speaking with us. And one of our big pushes is to also talk about healthcare transition. We have topic sheets, and I can pass these around. And this is some of the work that we do. We have families call us from soup to nuts, whether it be educational issues, play groups, camps, workshops, support groups, transition. We also, with the Federation, they offer a big conference once a year called the VOC. And these type of topic sheets are handed out every year. And basically, this is what we tell our families about healthcare transition and when to start, different information resources. This is my last one. I got some coffee.
We have an extra. We have an extra.
And one crown jewel of our program is our pink book. I don't know if anyone's familiar with it. This book is populated once a year. The resources are updated yearly or annually. And you can also search by disability. You can search by region. You can also find all the region coordinators and community support. And like I said, in terms of the healthcare tips on transition, these are some of the tools that we use over the telephone when families call us. And once again, when families are calling Family Ties, they dial in 1-800-905-TIES. Are you familiar with Family Ties, or has anyone here ever called a referral? No? Have you ever had our directory? No? This is a great resource to take back to it is a wonderful resource. People call months in advance before they're actually, I'm sorry.
I said we love it.
Yeah, people call months in advance before it actually is produced. Now I got a little bit ahead of myself. One of the things I want to talk a little bit more about was our parent-to-parent program. And in terms of how we support families, it's the crown jewel of our program, in the sense that a parent can call and find another family that has a child with an ailment or a similar disability and end up finding another parent. One of the beauties of our program is that we also, at times, people call with questions I have no idea how to answer. And I will call them back. We sit in 6 different regional Department of Public Health offices. I get to walk down the hall to many programs, whether it be a shelter program, whether it be early intervention. I can go downstairs to ABA and talk to one of their department heads and say, how would you handle this particular problem? So it's a beautiful marriage between the Department of Public Health and a Federation of Children with Special Needs to come together to create this collaboration called Family Ties. Any questions? And if you look inside of your packet, all the information that we have, it comes in Spanish, Portuguese, and in English. There are other languages available if you call our office. There's information about Mass Health, Mass Voices, Family Ties, the Federation of Children with Special Needs, The Department of Public Health, some of the programs that they offer: Catastrophic Illness Fund, Newborn Hearing Screen. And we also go out to different schools and CPACs, and we talk to families as well. We do, we go into resource fairs, we give classes in terms of what is family ties, what we offer. We have a program called Let's Get Organized. We help families, create binders and put together information to keep themselves organized to bring to doctor's offices. We also, like I said, we create topic sheets, and we're just there for the parents. Okay. And at any time, if anyone has any questions regarding education, we refer them back to the Federation of Children with Special Needs. There they can have a PTI training, that's a Parent Training Institute. They help families go into schools and advocate. They offer IEP classes. We have our Visions of the Community workshop that's offered once a year. And that's the big annual, it's an annual conference that is held with over, I want to say 8,000 to 10,000 people that attend each year. It's a wonderful experience for families. They offer daycare. They come in, the kids are there, the parents are there. They do breakout workshops and things of that nature. And that's it. And at any time, if you have any questions or problems, please don't hesitate to call. My card is inside of the folder. There's no problem that's too big. And like I said, if we don't know, we will find out. We all work together collaboratively. It's not an issue that we haven't been able to tackle. And if we don't know, we actually will call other families of providers to find out that type of information. My number is 781-774-6602. Like I said, it's inside on my packet. We also have, we work closely with Mass Voices, and they will also help with assistance in terms of if parents have questions about Mass Health, how to fill out the forms. There are the RCPs, the regional care providers. They actually go into homes and help families navigate healthcare. We have care coordination. They basically do the same type of work. And then, like I said, we do have regional coordinators that are in the area. Okay. Yes, sir.
So for families that need help getting Mass Health,
Mhm.
and we have language, different languages, the person that goes into the home speak their language.
If they do not, they're able to access a language line, and there is a three-way conversation. But for the most part, if they know beforehand, they'll try to take a community, a cultural broker with them to come in and help have that conversation.
For those people who want training through your programs, it sounds like they would need to find their own transportation to get there. Do you have any transportation assistance for them to get to your program for the kind of training that you offer?
Sometimes with the VOC, the Visions of the Community Conference, it happens once a year. There are buses in each region. I know for the Southeast region this year, the VOC is held at the Seaport Hotel once a year. There were 3 buses that came out of Taunton, so you had to get to the Silver City Galleria. If you could get there, they would bring you into Boston and bring you back. And if they're, other than that, we try to offer trainings in different areas around the city. If I am the Southeast Regional Coordinator, so I would do something like, say, in Brockton or Stoughton, in different communities. And if you call and request a training, we will come to the area, but it can't be just for one person. If you had a group of people, we would come to the area. Any more questions? No. Okay.
Can
You're very welcome.
The next section, what we were going to do is go over the PP. No, you're okay. Go over our PPOC goals. So these are the 2019 PPOC quality goals that have been identified. Some are similar to last year, increasing well visits 3 to 6 years. Last year's performance, we as a network, we were able to achieve 88%. Our target for this year is to increase to 89.3%. We have well visits 12 to 21 years old, and last year's performance was 76.4, and the target goal this year is 77.9. HPV vaccination is a new goal. The overall network performance last year was at 44.5, and so we're hoping to increase to 48.9 as a network. Chlamydia screening is a new quality goal for this year. Last year's performance was 79.7, and we're hoping to increase to 83.7%. And the ED utilization, we don't have the metrics here, but what we're hoping to do is to decrease the gap. So when you look at your ED utilization, your mass health patients utilize the ED at a much higher rate than your commercial patients. So we're hoping to narrow that gap, close it a little bit with ED utilization. So what we wanted to do is take this opportunity, and this was through feedback from MHCCs and providers, to be able to network with each other to discuss what you've identified as a goal in your practice for this year, and what steps or measures are you taking to try to achieve that goal, so that we can learn from each other, because one practice might be, knocking it out of the park, and we can take that information and apply it across the network. Is there anyone that would like to start the sharing of what you chose this year? And it doesn't have to be one of these goals. It could be a different PDSA that you chose to work on. Okay, thank you.
Yeah, so our actual goal for the practice this year is the HPV vaccine measure, and we are seeing improvements, but I wanted to touch more on the well visit because we did really well with it last year.
Great.
So I can share something with that.
Perfect.
So one thing that I did was I ran the My Practices Patients Report, and I went through and I filtered it so that the kids that haven't been seen the longest amount of time were at the top, and we went down that, and a lot of those, we ended last year at 80% for the 12 to 21 age range, but it really should have been higher because we had kids that were active that we hadn't seen since 2015, 2016. So filtering through those has really helped our percentiles and making sure that we don't have kids active in our system that really shouldn't be, that we haven't seen in quite a while. So it was a lot of certified letters, but it has helped our percentiles a lot.
Thank you for sharing. Have other practices done the same to clean up their panels with patients that have not been seen in over 2 to 3 years? And you can, inactivate them. And if they happen to call to make an appointment, you can always reactivate them. But cleaning up your panel, has anyone focused on transition of care of your adolescents that are 18 to 24? That anyone would like to offer any sharing of what you've done within that process? No. I know.
We start to let them know that that process is not we reiterated those visits. And when they do come in to their fund, we do give them a sheet of all the word provided that is taking the patient, and then try to do like a follow-up. But college,
it's hard. No, it's hard. And especially, you brought up a great point too with the college children. So even scheduling those well visits, try to schedule them a year in advance after they had that well visit, and look at that vacation time when they'll be home, spring vacation, summer vacation. Otherwise, if they're away at college, you miss that opportunity as well. What are some of the barriers that you're seeing as you're implementing your PDSAs around well visits? Is there anything that you might have questions for the group that you just can't overcome that barrier or obstacle?
The college kids, I think, are tough because if you've missed, like, if they turn 18, now you need to contact them as opposed to the parent.
Right.
So sometimes that can be a little bit tricky as far as trying to get them in, contact them. Certainly, you could leave a vague message or whatever that you had to the parent, but it really should be the patient.
You're right. Yeah. Yeah, and I know with my son, it's the same challenge. He's 19, and I know he has an appointment, but I have to remind him like a week in advance, 4 days in advance. Don't forget to go.
Yeah.
You're right. How about HPV? Did anyone take any? Go ahead.
So we took on the HPV vaccine. Traditionally, our rates, especially for the 11-year-old checkup, were quite low, mainly because a few years ago, as a practice, we made the decision that we were going to not offer 3 vaccines at that visit. And so we started asking families about it at 12, which usually meant they were ready to receive the vaccine at 13 or 14. And so we participated in the HPV challenge last fall and were able to increase our rates slightly. And then this year we started to routinely offer it. So we talked with nurses and providers so that we're offering it to all families at the 11-year checkup.
Okay.
And have had quite a pretty remarkable improvement already. We went from before we started the HPV challenge, having less than 10% of our patients accepting being vaccinated at 11, and we're up to 65 or 70%.
Congratulations.
So really,
Wow.
a lot of families are much more receptive than we thought they would be. And it, I think it was surprising to everybody. So we had nurses who felt uncomfortable offering 3 shots to an 11-year-old.
Right.
We thought families weren't really going to be that receptive to it. We also got everybody sort of speaking the same language as far as offering it routinely.
Yes.
So the nurse is saying you're due for 3 shots. Providers, for the families that were on the fence about it, being more proactive about recommending it more strongly. And so we've been able to, the next phase is we also have put up information in all the exam rooms about HPV.
Is that like a poster that you?
Yeah, so what we did is 2 weeks ago, there was the webinar. We had all the providers and nurses sitting on that webinar.
Okay.
And that really created a lot of momentum.
Yes.
You know, afterwards, we had nurses going to the CDC website and looking for posters and printing them out and putting them up in the exam room. So it really created a lot of momentum, and I think it's been very successful so far.
Was it a poster that you created, or was it one from the CDC?
No, it's one, we took some that they showed on the webinar. We went and found those online. We also looked through CDC and immunize.org to see what handouts they had available, and printed those, and now they're in all the exam rooms, so that when families are sitting there, it's sort of in their face every day.
Did you find that you changed the structure of how you had that conversation? Because last year you had started, did you change that at all in, trying to educate and present it to the patients and families?
Yeah, definitely. So one of the things that we did a long time ago as an office is had nurses, like at all of our visits, when they room the patient, basically say, these are the vaccines you're due for, right? And actually order the vaccines rather than the providers. And so the conversation changed from you're due for 2 shots today to you're due to 3 shots today. So right from the minute they're roomed, they're thinking, okay, there are 3 shots
they're gonna know ahead of time
that my child should be getting today. And then it's reinforced. Either if the family has questions, the nurse, I think feels more comfortable answering those questions. And then the provider, for those families that they sort of say, well, I want to ask the doctor about it or the nurse practitioner about it, that when the provider comes into the room, they're not just, if only 2 of the 3 shots were ordered, they're not just assuming that they don't want it. They're sort of saying, okay, let's talk about HPV.
That's wonderful.
So I think it's been very, it's been much more, it's been easier to increase our rates than we thought it was going to be. I think most families, depending on how you present it, are more willing to just go ahead with it.
Yeah.
Taking the focus away from it being a child's not going to be sexually active.
Right.
And making it cancer prevention. Has taken a little bit of that stigma away to many parents are more willing to be accepted at a younger age.
Yeah. Thank you for sharing. Is anybody else fighting? Okay.
Part of the CDC notes is educating to this question and science.
Mhm.
One of the other things that we try to do is talking about the vaccine. We talk about it as both 3 vaccines, but we put the HPV on both. So we say, let's do the meningitis vaccine, the HPV vaccine, the tetanus vaccine. One is meningitis, one is cancer, and one is pertussis. And so it's using the same tone of voice. And we, actually will tell you our concepts not there. We educate the providers better as well as the nurses.
Yes. Yes. Thank you. No, that's a great suggestion when putting it in the middle too, because sometimes if it's, you say it first, that's the first thing, it's what's going to hover, and then the last thing. So I think in the middle too makes it a little bit easier to did you, oh, I thought you were going to say something. Okay. Anyone else have anything on HPV?
We're experimenting with changing the vaccine schedule so that for the kids that are in the 7th grade, the following year, actually not offering the Tdap because we're talking about the cancer vaccine after first. And if we have 6 months of time, we're actually scheduling the Tdap. Getting HPV and the doctor out of the way, and then letting them know that the sooner or later they're for the Tdap, which is quite upsetting. We're putting that one off and giving them an opportunity to get that second HPV before they go on to 7th grade.
Okay.
Holding off the Tdap. Okay. And then coming in for the Tdap and the second.
And have you found that's had results with your rates?
We just started in the last 6 months, so it should be soon.
Great, great. Okay. And then how about anyone with chlamydia screening? Is that one?
I can talk a little bit about chlamydia screening. So the first thing is I didn't realize that as identified by a clinician, sexually active. So that's meaning, the SA screening in the history, if you're aware, that has to be checked off. So I went in and I looked at the report on SA and my patients who had missed it. And I was able to target that. Actually, a couple of my providers, one wasn't doing it at all, but another was checking off a different box. They thought they were doing it, but they were not checking off the yes, no box. And so right there, we were missing a lot of them because generally our chlamydia screening has always been very good because we have we call it a no white catch policy, 14 and up. All patients 14 and up, the nurses collect at the beginning of the visit a no white catch. Instead of saying a dirty catch, we call it a no white catch. And then if they decide that they would like to test for chlamydia at the end of the visit, then they have the sample available to send. And so that's been, we implemented that a long time ago. That's been, our chlamydia rates generally are very good, but it was skewed by the fact that the providers were not utilizing the identifying the patient's print.
Okay.
So it was too full of them.
And when you printed that report, even though yes or no was not chosen, it still showed up on that report? Is that what you were saying?
When I looked at the report, I filtered it by provider, and I saw that most providers, they were missing, let's say, 10 in a quarter, okay? And 2 of my providers were missing like 125.
Okay.
So there was such a disparity. I was like, okay. And then when I looked, one I could tell they were checking off a different box. So I realized, oh, he's not checking off the yes, no, that's why.
Okay.
And the other provider, I could tell wasn't doing it at all because there was nothing checked off.
Thank you. Anyone else with chlamydia? How about ED? I know that's a tough one. Has anyone tackled that one? Or even if it wasn't one of the PDSAs, have you changed anything within the past couple of years that you're noticing that's making a difference?
And we went through, we pulled all the lacerations to determine which ones were actually putrid, which ones were dermabonded. And then we changed our program for the procedure so that they would bring in more patients here. Criteria of what probably would be putrid. And so we haven't gone back now to reevaluate to just simply do that. But we're hoping that, I can't tell you whether it's going to be, the outcome is going to improve. But we're hoping that.
Great. Thank you. One thing to think about too, not that it will make a significant impact on reducing that gap, but if you have patients that have complex needs or socioeconomic needs and they're frequently utilizing the ED, you can also make a referral to the regional support team, and we can also outreach to the family and see, is there any support services that we can align? Is it a cost thing, maybe going to the ED because they don't have transportation, but they can use that ambulance to go? So we can even help that way to just go out, meet the family, do a health needs assessment as well, identify if there's any barriers they're facing within the home environment that could help, and do some education as well. Any, oh, sorry, Shelley.
So we recently hired a marketing company for our practice, just recently, who's now tweaking like our Facebook. We now are on Instagram. We know that we do our website. So I think the hopes is that by putting it out there, more feel like advertising our office hours. Because despite the fact that we're there 363 days a year, our patients still don't have any idea that we're open, 8:30 in the morning till 7:30 at night. We're open Saturdays, Sundays. We are literally closed Thanksgiving and Christmas, and that's it. Yet they always go to the because our focus is through social media and marketing that maybe those numbers will go down.
How about with transition of care calls after? Do you utilize the ED report or inpatient report to do transition of care calls?
The home triage nurses do all of the follow-up calls.
Because that could also be opportunity too. So if you know that you have a patient who is frequently utilizing the ED, when you do that follow-up call, you can also send that friendly reminder that we are here, and it's pediatric specific care that they receive when they come to your practice versus going to the ED, less of a wait, things like that. So sometimes just that language and scripture around it. What we're also doing, I'll just elaborate a little bit, it's not necessarily just with ED admission, but it's with the inpatient admissions. What we're trying to do is improve the communication that occurs on admission, and then also, between the hospital and the healthcare team in the practice, and then also that transition of care call to the family. So we'll be starting a PDSA pilot with 4 practices in first week of July. We'll start, and we've set it up right now with Boston Children's Hospital Nurse Care Management, and I'm not sure if it'll be the MHCC or the triage nurse in the practice, whatever the practice's preference is. But when a patient is admitted to BCH, there will be a warm handoff that occurs from the designated medical home person to the Boston Children's Nurse Care Manager, so they can just, discuss, what the practice knows about the patient and family, the challenges, things like that. And then on discharge, which is the most important piece, on discharge, Boston Children's Care Manager will call the medical home and give a warm handoff to the designated person, whether the MHCC or triage nurse. What we've also built into Epic, which we'll be trying, is a handoff letter. So it'll be easy for the practice to provide that handoff and fax the documentation over, but we still want the verbal handoff to close that loop as well. But that Epic handoff letter, it's standardized in an IPASS format, and it will pull in relevant documentation within the medical record, so you're not having to redocument anything. And then you can just add anything that's not, included in the letter, fax it off to BCH Care Management, and then that will be the indicator for them to identify who and how can they contact that person in the medical home to get that handoff. So we're going to pilot that in 4 medical homes, and hopefully, work out the kinks and be able to expand that, to other hospitals and more medical homes. And then the next step to follow on that is the transition of care phone call. I know that, the medical homes provide transition of care phone calls to patients who have been in the ED and inpatient. So we're going to try to standardize, help you to standardize that phone call in an IPASS format as well, and give you some scripting if that'll help. And then at the same time, when you're making that phone call, to be able to evaluate, is this a patient that has had a new diagnosis, has changing health needs, or their, DME equipment, things like that, that maybe the regional support team can help you as well through that transition of care. So it'll be an opportunity to identify that on that transition of care, and then send that referral in as well, because we really want to collaborate and support everybody in, providing the, the best care experience and transition of care for patients and families.
We're not seeing it as much as we are minute.
Oh, yeah.
But those, I find, parents don't want to hear anything you have to say other than, they're like, well, let's just talk to them, and get right in.
I know it's hard, especially when it's that same copay that they would pay.
Suggestions on what we say to them as far as those?
I think, again, it's just the scripting the language, the conversation that you have with the patient and family. Again, you are the providers, the healthcare team that know the patient's care and can provide, pediatric specific care. Having those, do most practices all have sick visits available same day? Yeah. So even just reminding them that they can call and get a same day sick appointment. But again, it's being able to be provided that, the quality care by their pediatrician versus a minute clinic. But you're right, it is tough because you walk in, but there's always a wait too. So if they can schedule a sick visit and come at the time of their visit versus waiting in the waiting room for an hour to be seen. And then there's also what the providers receive, the management partner, are the opportunity packet. So they also show you ED visits and minute clinic visits, and you can evaluate, what days of the week, what times of the day are most of those visits occurring, and you can also compare that against your office hours. And maybe it's something that, maybe shifting, you might be open late one day of the week, but maybe more the outside visits are occurring a different day. That might be a suggestion to look at.
We have a little poster in our office in every single room on the back of the door, and there's one in both ways. And it talks about, utilizing the minute like person.
Yeah.
And it's like, where ignorant.
Is that something that you would be able to share with other practices in case they wanted to replicate something? The other thing, a suggestion might be, I don't know, is anyone using the my portal, my chart for scheduling online visits? Starting to. And I'm wondering if that might even make a difference, just out of convenience, because again, it's easy, you're driving home from work, and because, as a parent, it's difficult to take time off from work, and you need to get your child in. So whether it's, even just convenience that mom or dad can look in that portal and say, oh, this appointment works well for my schedule, let me take this one, versus taking the time to make a phone call and wait. I mean, maybe that will make the difference as well. And you can also do it at 8 o'clock at night as you're sitting on your couch. And
I've been confident also when we're doing homework, probably doing the asking, oh, why did you go there and not come here? We're married, for David, and not a lot, but I've heard quite a few times that they say, oh, there's Boston Children's Hospital physicians at St. Luke's, so that's why we choose to go there. And there is a lot of advertising on the radio locally about those physicians being there, but there is no they don't mention on the radio or anything like that, like, oh, for emergencies only. They don't push that. So a lot of times we say, oh, well, they're there, so that's why I chose to go. So it's kind of we're kind of not wanting them to go there, but they're hearing this all from Facebook, from the radios, and they're there, so why not use it? Right.
It's
I have a lot of other practices that very experienced that too. Just a lot of work with the customer and how to run leadership and to the hospital leadership to make them aware of that. So I don't know if there's anything else, but when they do the fundraisers, I think it's very important.
Yeah,
The restaurant one.
Yeah. I think they changed that though, where it's South Coast to, it's not just Boston. I don't think, that's just somebody told me, it's good, finally, it's not go to the ER. Yeah.
One of our patients, and the parent that's running that, you tell her provider, can you tell her something? Oh, okay. Yeah. Right.
I think somebody had a hand up in the back. Was there still a question or somebody wanting to share?
I just had a question about the iPads.
Yes.
Is there a template in Epic, or let's say, for example, you want to send a patient that would be an iPass template so that we're using the same language to and from?
Okay, there is a template. I can share with you what we did for the handoff for the medical home. There is a template for the iPass. I can show you within how to script that, with the, information, the patient summary, and I can send that to you as well. And then that's a great idea. I know that Boston Children's, Anna or Megan, do you remember what it was called? Boston Children's did a handoff with their ED. I don't remember the name of it, and it was in an iPass format when sending a child over to the ED. I'll see if I can remember what that was and share that with you as well. Any other sharing or a different goal that was not on here, or a struggle that you just don't know how to approach? Okay. Did you find this helpful to share the stories and that maybe you can get some ideas to take back to your practices? And
Cheryl?
yes.
I have a question from earlier, not
Yes.
this, but just, it was more so, has anyone ever referred directly to like the tough care management program and or that LTSS? Like, have you in your role, have you actually, how many have, like, if you have? One? Okay.
What we've been doing too is Tufts Care Management does their own health needs assessment. Sometimes they identify a child, whether it's on a high cost utilization report, an admission to the hospital, being discharged, because they get that information before we would through the regional support team, and I'm not sure if they get it sooner than you do. So they do a health needs assessment that sometimes identifies needs as well, or a parent may call Tufts to identify needs. So what we've asked them to do is also have Tufts call the regional support line before outreaching to the patients and families, because what was happening in the past is they were independently reaching out to the families and offering some sort of support services, which is great, but then when the patients and families came into your practice and they had questions, you were out of the loop and didn't know what was going on, and that could be an uncomfortable situation too. So what we've asked them is to contact the regional support team, one, so that we could check with the practice to see if they're already aware of those needs, because the medical home care coordinator may already be addressing those needs. And we don't want to duplicate services, but if they're not aware of it, we want to make them aware of it as well. The other challenge that was happening when Tufts outreaches to patients and families, you're making those cold calls. Patients and families may not know who's calling, why they're calling as a telemarketer, and they don't answer the phone, so Tufts can't connect. So where it's been valuable with the medical home care coordinators is you can help build that relationship. So what we've been doing is calling some MHCCs to say, you know, Tufts has identified this patient, they haven't been able to connect with them. Would you be able to make an introductory call to the patient and family to let them know that they're calling and this is the reason why? And we've also done the same thing with the LTSS. There's a hard to reach list, report. So once that participation form that we know they have it, but if they're not making connection, sometimes going through the medical home care coordinator, we can identify, does the patient have an upcoming visit, or could they make a phone call to say that they've been trying to get in touch with them? So that has been helpful a little bit, but ultimately we want to keep all the information coming in and out of your practice and not having silos of everybody duplicating the efforts and nobody talking to each other is what we're really trying to do. But if you don't, like I said, if there's a barrier, a challenge, and you're not sure who can help, but you need help, just call us and we'll talk with you and we'll figure out which is the best path to make that referral to. I apologize, the fire alarm interrupted that last presentation. Okay. And then this is a slide just showing the upcoming webinar Wednesdays that we have. And we'll be sending the slides out as well, so you don't have to write everything down.
Does emergency response in primary care mean fun? Like an emergency response in the office, following up with patients that have an emergency?
It could be a little bit of both. And what we did was we put together, and some of this is in that webinar, we put together a PPOC emergency response. So if you remember when there was the gas explosion and that affected some vaccines in the medical home, and it was communicated and working on, but then we recognized we had an opportunity that we can improve to provide more support for the practices, that if we created an internal PPOC emergency response team, which includes myself, Nicole, John Hattoon, Lewis, Greg Young, Tammy, so that we could say, hey, FYI, this is what's going on, because there may be other team members that we have that could have some more valuable advice or guidance that we could resolve that situation. So again, it's about the collaboration and getting the support that you need, as quickly as you need it. So Nicole will be doing that. She was the one that was put that whole plan together. Yes. Yes. And then again, the nursing contact hours are available. You just need to sign in and then complete that post-session survey, and then we will email those certificates. And then again, the meeting evaluation is really important because we really value the feedback and recommendations you have for us. So that is where, you know, we've changed the structure a little bit to add some networking and collaboration with each other. And then we are relooking at the structure of the Zoom, and not the MHCC meetings with attendance versus maybe a Zoom. There has been a lot of requests to offer a Zoom option. So we are looking at that, and hopefully we'll be able to make that available. But with the MHCC salary support, it is still required that you have to attend 3 in-person meetings. So if you did attend one in Zoom, it wouldn't count for credit, but at least you would be able to participate in real time and be able to ask questions versus watching the recording later on. We thought that would be more valuable. So we are looking at trying to make that an option as well. And these are the upcoming meetings. So there's one August 14th and December 18th. And that is the conclusion for our meeting. And I apologize for the technical difficulties early on with switching back and forth and then the fire alarm. But I hope that you found that this was informational and valuable to you.